Continuing to look at anatomy with respect to motions as the central portion of our network of meaning or of our semantic network, we're looking at hip adduction or hip adduction. Our objectives is to have a specific discussion of what hip adduction is or hip adduction is with respect to planes and axes, general discussion of the muscles that perform this action, the neurovascular bundle. Then we'll have a general discussion as we go, as well as specific discussion at the end of areas to assess and treat should hip adduction issues be suspected by the practitioner or reported by the patient. So as we consistently do, we do a quick review of planes. The sagittal plane is a 50% cut of the body left to right. The horizontal or transverse plane is a 50% cut of the body top to bottom. The frontal or coronal plane is a 50% cut of the body back to front. With axes being perpendicular to the planes, the sagittal plane has a horizontal or transverse axis. The horizontal or transverse plane has a vertical axis, and the coronal or frontal plane has an anterior to posterior or posterior to anterior axis, depending on the terms you like. In the case of hip adduction is movement of the thigh towards the midline of the body. So if this was the thigh, it would be this movement. That movement occurs in the frontal or the coronal plane against the or in the anterior to posterior axis or on the hypothetical anterior to posterior axis. There is no actual clear axis with respect to the coxofemoral or the hip joint on account of the fact that it is a ball and socket joint, which means it's multi-axial and multiplanar. Therefore, it is a hypothetical anterior to posterior axis in the frontal or coronal plane about which the thigh will come towards the midline of the body. The thing that will stop adduction is contact with the opposite thigh. So there isn't necessarily a specific structure to restrict it, but it will bump into the other thigh eventually, whether it goes behind it, in front of it, or directly towards it. One leg will eventually run into the other. But it is movement towards the midline of the body in the coronal or frontal plane about a hypothetical anterior to posterior axis. The muscles that are going to perform this are going to be your adductors. All right, so specifically with respect to adductor magnus, you're looking more at the pubofemoral portion as the primary adductor. The ischiocondylar portion is going to act a little bit more as a hip extender, but both are going to contribute to some degree to hip adduction, but primarily the pubofemoral portion, adductor minimus, which sometimes is present, sometimes it isn't, sometimes it is just considered a mildly differentiated portion of adductor magnus. You're going to then have the adductor brevis and longus. You are then going to be considering the gracilis, the pectineus, the external obturator or the obturator externus, and the quadratus femoris as the muscles that are going to generate hip adduction, which means that as far as the areas that you're going to be examining with respect to the soft tissues themselves, it would be primarily the medial compartment of the thigh, somewhat anterior, somewhat posterior, but generally the medial compartment of the thigh as far as the muscles themselves that are going to perform this action. You're generally looking at yield to pressure of soft tissue there, or possibly moving perpendicular to soft tissue direction, which would still be yield to pressure because you're trying to get the soft tissues to yield. So your finding would be everything moves as or yields as you would expect it to, but there's an area that doesn't yield or move as you would expect it to. Therefore, that is your positive finding, the area of high tone. That's what you work on. With respect to the neurovascular bundle, here you're looking generally at the lumbosacral plexus. So you're looking at some direct branches from the sacral plexus, things such as quadratus femoris with respect to the obturator nerve. So the majority of the neurological tone as far as motor innervation for adduction is off of the obturator nerve, which is more from the lumbar plexus. So as far as where you're looking with respect to nerves, you're looking at the lumbosacral region. So you're going to look at the lumbar column, you're going to look at the pelvis, very generally speaking, neurologically. With respect to the vascular side of things, you're going to be looking somewhat at the inguinal region, somewhat at the anterior soft tissues of the thigh, somewhat, and then definitely at the medial soft tissues of the thigh. You may be considering the lumbar column as well, the descending aorta, the abdominal aorta, the common iliac, the internal iliac, the external iliac, then the femoral artery and branches thereof, the obturator artery. So that means that you're looking lumbar column, pelvic region, inguinal ligament, anterior soft tissues of the thigh, medial soft tissues of the thigh as far as the neurovascular bundle is concerned, which again helps us make the case that if you are identifying motion problems, either in the form of large motion, identifying smaller problems as subcomponents of the large motion, or yield to pressure of soft tissues, you will behave according to the problem at hand, as opposed to chasing the whole neurovascular bundle, expecting to find something. If you do a general assessment of the whole body, you find specific issues with hip adduction, then based on your movement findings, you will behave accurately to the problem at hand, as opposed to chasing the whole neurovascular bundle. Now, there's value in understanding the path of the neurovascular bundle and the specifics of it. However, your treatment is best based on movement findings. So as we've already noted in this discussion, for areas to assess and treat, the lumbar column for neurovascular bundle, the inguinal region for neurovascular bundle, the anterior and medial soft tissues of the thigh for muscles primarily, and the neurovascular bundle. As with anything with respect to the lumbar column or the abdominal region, rebound tenderness. So you push on the abdomen, no pain, you let go, and there's pain. That is an immediate red flag, because it could be a visceral pathology, which would be unknown as to what it is. You refer that out, that's a red flag. Known fractures or tears in any of the regions discussed, you do not treat. That is a red flag. Suspected fractures or tears in the region, you refer out for differential diagnosis to an appropriate professional. If they do not identify a fracture or a tear in the regions that you're concerned about, then you may treat. However, you still want to be cautious. With a known fracture or tear, you can treat the patient, but you don't treat the fracture or the tear.